Now I will discuss with you pre-anesthetic evaluation. Now, pre-anesthetic evaluation, very important topic from exam point of view. If you pick up the recent 5-year All India AIMS and any other exam paper, there is always a question on pre-anesthetic evaluation, right? A small topic, fixed things we have to know. If you know those things, you won't do a wrong answer in pre-anesthetic evaluation. What we have to study in pre-anesthetic evaluation? I would discuss 3 things in pre-anesthetic evaluation. How do we do pre-anesthetic evaluation? In which I will focus on ASA grading, American Society of Anesthesiologists grading. Then I have to discuss with you airway evaluation. How do we do airway evaluation? And then I have to discuss with you how do we do, let's say, write pre-anesthetic orders. In pre-anesthetic orders, there are so many orders which we write, but I would focus on 2 things which are asked in exam. One is, that is nil per oral order, and the second is, that is orders regarding previous medication. Patient may be on one or other medication. Which medication we stop prior to surgery, which medication we continue till the day of surgery has clear-cut recommendation. So we have to be aware of all those things. Okay, so let us start with pre-anesthetic evaluation. How do I do pre-anesthetic evaluation? So I hope a lot of you must have done a pre-anesthetic evaluation along with your anesthetist in PAC room. How do we do it? As we take any history, we take the history of patient. The first thing we do, we take a history of patient with an added history of any drug allergy. Routinely also we take it, but we focus more on it, of any drug allergy or let's say previous anesthetic exposure, etc., etc., right? Then we do a general examination, right? General examination, right? Routine general examination like any other general examination. Then we do systemic examination. We do a systemic examination, right? After doing systemic examination, we let's say see some investigations, some routine investigations of the patient. So we see some investigations. After seeing these investigations, the first thing we do, we assign a ASA grade, American Society of Anesthesiologists grading. So I would talk about ASA grading, American Society of Anesthesiologists grading. Okay, American Society of Anesthesiologists grading. We call it ASA grading. ASA grading, right? Now, what does this ASA grading tell us? Like, I am the anesthetist who has done this pre-anesthetic evaluation and has given an ASA grade of 3, and some other anesthetist is getting the case done. He would not repeat all these things. He would know what does ASA grade 3 or 2 or 4 means. So what does ASA grading tell us? It gives us idea of 2 things. It tells us about the present physical status of the patient, and it tells us about the risk associated with surgery, right? So present physical status, and it tells us about risk associated with surgery. Okay, present physical status and surgical risk. Okay, guys. Now, let us talk about ASA grading. ASA grading, the first thing which I want to tell you about it is, we do it for elective surgery, planned surgery. If I want to do it for, let's say, emergency surgery, same grading system if I want to do for emergency surgery, then if I want to do it for emergency surgery, then we write 1E to 6E. For elective surgery, the grading is 1 to 6. And for emergency surgery, the grading is 1E to 6E, right? E stands for emergency. Emergency surgery. Got it? So 1 to 6 is elective grading, 1E to 6E is emergency grading. Remember, always, if it is written ASA grade 1, it's an elective surgery. 1E is necessary to write for emergency surgery. Got it? Okay. Now let us discuss what is this grading. 1 to 6. 1. ASA grade 1. Guys, patient came for lap cholecystectomy, appendicectomy, any surgery. When I took the history, there was no complaint of any other comorbidity or disease, anything. Patient was as good as a healthy person. He had no problem. Whatever problem he had, it was related to the thing, to the system for which he was being operated. Whatever problem he has, let's say for lap cholecystectomy patient, whatever problem he had, it was related to cholecystitis. Apart from that, he had no problem. So ASA grade 1 localized problem. Or number of times we say a healthy patient. Patient, he's a patient, but it's a healthy patient. Got it? A localized problem or a healthy patient. So, localized problem. Okay? ASA grade 2. Patient came for lap cholecystectomy, right? And when I took the history, he said, doctor, I am hypertensive from last 5 years. On regular medication, I get my blood pressure checked also every month. It's fine. It's within normal limit. Then I ask him, do you have any problem in normal activities? Day-to-day activities? No, doctor, I can do it. Do you have any problem in strenuous activity? Can you carry out? Can you play tennis? Can you run? Can you climb 3 flights of stairs? Of course, doctor, I can do that as well. Patient has a comorbidity. It is controlled. He takes regular medication. His blood pressure is within normal limit. His investigations are within normal limit. He has no problem on carrying out normal activity or strenuous activity. ASA grade 2. Controlled comorbidity. There is a comorbidity with no or minimal risk. Okay? So controlled comorbidity. Controlled comorbidity. ASA grade 3. Okay. Patient came for lap cholecystectomy, right? Or patient came for herniatomy, whatever. And when I took history, patient said, I'm hypertensive from last 5 years on regular medication. His blood pressure, when I measured, was within my acceptable limit. His ECG and other investigation was within my acceptable limit. I asked the patient, do you have any problem in normal activities? No, doctor, I can do it. Can you climb 3 flights of stairs? Yes, doctor, I can do it. But when I do it, I become dyspneic. Can you walk for 5 miles? Yes, doctor, I can do it. But when I do it, I become dyspneic. Patient has a comorbidity with no limitation in his normal activity, but becomes symptomatic on strenuous activity, right? This is comorbidity with moderate limitation, right? So comorbidity with moderate limitation, right? It is comorbidity with moderate limitation. Patient has a comorbidity with moderate limitation. Okay. ASA grade 4, right? I'm sitting in my PSC room and patient has to come from the gate, hardly a distance. Patient should reach me in 10 seconds. But patient cannot walk a step. He walks, becomes dyspneic, sits. Again 2 people holds him, again a step, again dyspnea, again sit. He cannot carry out his normal activity like walking, talking, eating, etc., etc. Guys, his comorbidity is deteriorated to that extent that it's a constant threat on his life. He cannot survive, right? Any time he can die because of his comorbidity. Got it? It's a constant threat on his life. We never take any patient of ASA grade 4 for elective surgery. He cannot carry out his normal activity. That is, he cannot maintain his normal cardiac output also. How can he maintain the cardiac output during surgery and anesthesia, which requires more than normal? Patient will come out of the OT table. So we optimize. Once the optimization is fullest, then we carry a risk-benefit ratio. If the benefit of surgery is more, then we take patient for surgery, right? If risk is small, we defer surgery. We defer surgery in a number of conditions. Okay? So ASA grade 4, comorbidity is constant threat on his life. Guys, comorbidity and always symptomatic. 4. Comorbidity and symptomatic on moderate activity. 3. Comorbidity with no symptoms. 2. No comorbidity. 1. Correct? Okay. AC grade 5. Surgery is the only option for survival. Surgery is the only option for survival. Surgery is the only option for survival. Patient will die if not operated. Even if patient is operated, there is a huge chance that he will die. Whatever chance he has if the surgery is successful. In desperation, we put the patient for surgery. Guys, I had a patient with a huge mediastinal mass. His mediastinal mass was encasing his lung and heart. The patient was dyspneic at every time. He cannot sit or be supine or eat. He was totally in a miserable condition. But the tumor was encasing the lung and heart, so it was a very risky surgery also, right? But anyways, since this was the only chance for the survival if we could debulk the tumor. So we took the patient for surgery. Well, patient couldn't come out of the surgery, right? Patient couldn't come out of the surgery, but whatever chance he had, if the surgery was successful. So in desperation, we had taken the patient for surgery. This is ASA grade 5. Surgery is the only option for survival. Got it? ASA grade 6. Brain dead patient whom we are taking for organ harvesting. Brain dead patient. Brain dead patient for organ harvesting. Brain dead patient for organ harvesting. Got it, everyone? This is ASA grade 1 to 6. Got it? So this is very commonly asked in exam. Especially, I have seen maximum question they have asked on ASA grade 3. They tell the patient has some comorbidity and make the patient symptomatic on some strenuous activity. That's the maximum question I have seen question on. So keep it in mind, this ASA grading. After doing ASA grading, the next important thing for anesthetist is airway evaluation. Since we have to secure the airway during anesthesia, we have to see that is there any anticipated difficulty in securing airway? We have to assess for any difficulty which we can face so that we are prepared for it. So airway evaluation. Airway evaluation. When I discussed with you airway, I told you how do I secure the endotracheal tube and other airway devices. We do so many maneuvers. Like for example, for intubation, I make a proper position. There is movement on atlanto-occipital joint and neck joint. So I have to see the movement of these joints. If the neck of the patient is fused or rigid, patient has a cervical spine problem, it cannot move the neck, then the positioning would become very difficult and intubation will become difficult. If there is problem in atlanto-occipital joint, the same problem would happen, right? Then what we have to do, we open the mouth of the patient. Guys, I have to insert my laryngoscope or my airway device, I have to open the mouth. Now mouth opening is not adequate. If mouth opening is not adequate, I have to look for other means. So it makes the airway difficult. Then guys, I see this is mentum and hyoid bone distance. Thyroid bone distance. Mento-hyoid, mentothyroid distance. Mento-hyoid, mentothyroid distance. Sorry, mento-hyoid, mentothyroid distance. This gives us an idea. Of how much we have the intraoral space, right? Then we see the appearance of patient, right? That patient has let's say a bearded look with which mask holding will become difficult, a lot of fat in his neck or short neck, right? These all would make the mask holding and laryngoscopy difficult in the patient. So we evaluate the airway, and along with this we do one grading that's called Mallampati grading. Last All India they asked question that what is the role of Mallampati grading in airway evaluation, pre-anesthetic evaluation? It assesses the difficulty in intubation, Mallampati grading. Now what difficulty is assessed by Mallampati grading, we have to understand. So let us discuss airway evaluation with focus on Mallampati grading. So number 1, we see the appearance of the patient. We see the beard, we see the neck, size of neck, we see the fat on the face, etc., which can make the holding of the mask difficult, right? So appearance. Then we see the joints movement. We see the atlanto-occipital joint movement. We see the neck joint movement. We see the mouth opening. We see mentothyroid distance, right? And one very important thing we do is Mallam Patti grading. What is this Mallam Patti grading? Now there must be so many of you who may have done it. How do we do this Mallam Patti grading? I ask the patient to sit in front of me at the same level, eye level, same, and ask my patient to open his mouth. Okay? Then I ask him to take out his tongue without vocalization. Open your mouth, take out the tongue, do not vocalize, do not make any sound. If the patient will vocalize, it will increase the tone of the oral cavity and the assessment may be affected. So I just ask my patient to open his mouth and take the tongue out. Then I peep inside his oral cavity and try to see the structures of oral cavity. And what do I see? I see this. Class 1. I have full visibility of every structure of the oral cavity. I can see the tonsillar pillars, fauces, uvula, soft palate, hard palate. I can see everything, right? We write class 1, Mallam Patti class 1. If I miss one or two things, I write class 2. If I see only hard and soft palate, right, then we write class 3. And only hard palate, then I write class 4. Now what is gradually happening? Why I am interested in seeing these tonsillar pillars, uvula, hard palate, soft palate? Well, when I do laryngoscopy, I don't even bother to see these structures when I put my laryngoscope. If I try to see so many structures, I will take so much time to do laryngoscopy. Then why in pre-anesthetic evaluation I am wasting my time? Actually, what I am doing, I am not interested in this structure. I am interested in assessing the size of tongue. If you see this, what is gradually happening from class 1 to class 3? Tongue is increasing in size. Tongue is gradually increasing in size, right? Guys, if tongue is big, it will be difficult to push the tongue out of my way when I put the laryngoscope inside the oral cavity. If tongue doesn't go out of my way, what will happen? I won't be able to see the epiglottis. If I won't be able to see the epiglottis, how would I lift it and see the glottic opening? Got my point? So what is Mallam Patti grading? It is assessment of size of tongue with respect to oral cavity, right? It is assessment of size of tongue with respect to oral cavity. Mallam Patti grading is assessment of size of tongue with respect to oral cavity. Okay, we have Mallam Patti class 1, 2, 3, 4. Mallam Patti class 1. Hard palate, soft palate, uvula, fauces, tonsillar pillars. Okay? Class 2. I see hard palate, soft palate, maybe uvula, but I miss fauces and tonsillar pillars. Class 3. Hard palate and soft palate, and I miss all other structure, nothing else. Okay, then class 4. only hard palate, and rest of the structure I am unable to see, nothing. Got it? So guys, class 1 and class 2. Class 1 and class 2, normal tongue. Class 3 and class 4, large tongue. Difficulty in intubation. Difficulty in intubation. So Malam Patti is assessing difficulty in intubation by assessing the size of tongue. See guys, if you have inadequate mouth opening or inadequate mentothyroid distance, that's also tell us difficulty in intubation, right? What difficulty is assessed by Malam Patti? Size of tongue with respect to oral cavity. Got my point? This is Malam Patti grading. Okay, guys, here I want to tell you one more thing. It has still not been asked in exam, but since Malam Patti has been asked quite a few times, just keep this also in mind. Just know what is this, and what I am trying to tell you, Konmark Lehane grading. Konmark Lehane is grading. Guys, this Konmark Lehane grading is laryngoscopic view of glottis. When we do laryngoscopy and how much glottic opening I am able to see, that's grading is Konmark Lehane is grading. It is not a pre-anesthetic evaluation of airway. It is laryngoscopic view of glottic opening. So just write it. Konmark Lehane is laryngoscopic view of glottic opening. Glottic opening. Okay? It is laryngoscopic view of glottic opening. Got it? So this is all I want to tell you about Malam Patti grading, right? Now, after doing the ASA grading, Malam Patti grading, airway evaluation, etc., etc., now we have to write pre-anesthetic order. Now, in pre-anesthetic order, I give a lot of orders. I take a written informed consent. I ask my patient to take some pre-op medications to relieve his anxiety, or to maybe to decrease his secretion if it is too much, or to decrease his pain if it is having some pain. Okay? So I give a pre-anesthetic operative medication to him, pre-operative medication. Okay. Then I tell my patient regarding nil per oral, how many hours NPO he has to remain prior to surgery, right? I also tell my patient orders. I tell my patients about orders regarding his previous medication. Patient may be on one or other medication. Which medication we have to stop, which medication we have to continue, has a clear-cut demarcation. So orders regarding previous medication. Orders regarding previous medications. Guys, we will concentrate on nil per oral instruction and instructions regarding previous medication. Most of the questions are asked on this. Okay, so we will concentrate on these two. So let us first discuss nil per oral order. Nil per oral order. Now, nil per oral order for adult and pediatric is different. If I have an adult patient, okay, adult patient, then I asked him to remain nil per oral 6 hours prior to surgery, right? I asked him to take light, semi-solid food at least till 6 hours prior to surgery. So 6 hours prior to surgery, I ask him to remain nil per oral. And if he wants to take his full-fledged meal, I ask him to take his last meal 8 hours prior to surgery. So 8 hours prior to surgery for solid, for full-fledged solid food. But semi-solid liquid till 6 hours we allow the patient. Okay? Liquid till 6 hours prior to surgery. Okay? If it is pediatric, then 8, 6, 4, 2. 2 hours nil per oral for clear fluid. Clear fluid like water, clear fluid like apple juice, that is fluid with no particulate. 4 hours NPO for mother's milk, breast milk, for breast milk. 6 hours NPO for formula milk, outside milk, formula milk. And 8 hours NPO for solid. This is the scene of pediatric. Guys, this used to be seen, still 90% centers practice this, but one year, there has been some change done in this. This 2 hours NPO for clear fluid has been further reduced to 1 hour. This is the latest change, right? I am telling you, and still I am telling you the older thing also. So depending upon how the question is framed, you can answer. If they ask how many hours NPO we have to keep a child prior to surgery for clear fluid with 1 hour in the option, 1, 2, 4, 5, whatever, then it's a new question. Normally, the older question, they used to give 2, 4, 6, 8. The answer used to be 2 hours, right? If 1 hour is in the option, they have framed a new question. Go for 1 hour as an answer. But otherwise, if 2, 4, 6, etc. is in the option, go for 2 hours as an answer. Okay? So this is the scene of pediatric. Okay? So this is the scene for your NPO order. Now, very important, orders regarding previous medication. Orders regarding previous medication. Guys, there are hundreds of drugs. I cannot discuss every drug with you. The drugs which I am discussing with you has to be continued or stopped prior to surgery. Drugs which I am not discussing with you has no clear-cut instruction. So what is the approach for the drugs which doesn't have a clear-cut instruction? Continue till the day of surgery. We ask the patient that to take his routine medications till the day of surgery with a sip of water. Why to disturb a serum concentration of a drug which if it has no implication on anesthesia and surgery, right? So whatever drug which has to be stopped, which has to be continued, I would discuss. The drugs which I am not discussing, the latest trend is to continue take the regular medication with a sip of water. Got it? So let us discuss the drugs which has clear-cut recommendation. Okay, so starting with oral antihypertensive. Oh guys, there is a lot of controversy in this, that we have to continue all of them except ACE inhibitor, ARBs, etc., etc., etc. There is no controversy actually. ARBs and ACE inhibitors we were stopping in 2005, but from 2005 to 10 all the RCT trials showed that when we were stopping them, then there was more problem than continuing them. Why were they stopped? Because of the risk of intra-op hypotension, easily managed by good anesthesia and monitoring. So not a problem, right? It was not a problem, right? Now, very important, when we were stopping them, their serum concentration was getting disturbed and patient was facing a lot of problem post-op. So in 2010, the recommendation was upgraded. All antihypertensive, yes, all of them, has to be continued till the day of surgery. I ask my patient, what do you take as your antihypertensive drug? Okay, this drug. If you take it in the morning, take it with a sip of water. If you take it in the evening, take it with a sip of water. Do not disturb your morning antihypertensive drug dose and timing. Okay? So continue till the day of surgery without any dispute. Continue till the day of surgery. Okay? Continue till the day of surgery. Okay? So there is no dispute. We have to continue them till the day of surgery. Okay. Second. Guys, oral hypoglycemic. Now definitely we have to stop them because we have kept the patient NPU. If we continue them, patient will go into hypoglycemia, and you know that hypoglycemia is more detrimental than hyperglycemia. Hypoglycemia doesn't give us time. Hyperglycemia we can manage, right? So we have to stop them. And whenever you stop them, stoppage of these drugs, anesthesia and surgical stress and risk always impairs the blood sugar level. So blood sugar level would get impaired. Mild and moderate surgeries, little impairment of blood sugar level has no implication on the outcome of the surgery. But major surgery like cardiac surgery, vascular surgery, outcome of surgery is dependent upon the blood sugar level. We need a tight glycemic control. So for minor and moderate surgeries, we simply stop them. The last dose, we simply stop them. And major surgery, we have to stop them, of course, but we have to keep the patient on insulin and monitor his, let's say, blood sugar level, right? So, minor, moderate surgery, stop, 24 hours prior to surgery. Major surgery, stop 24 hours prior and put the patient on insulin. Put the patient on insulin. Okay? We have to put the patient on insulin. Got it? Understood this? Okay. Then comes antipsychotic, antidepressant, anti-epileptic. Antipsychotic, antidepressant, anti-epileptic. Okay? Now very important. If we stop them, stopping them, surgical risk, anxiety, everything can precipitate these conditions. So we have to continue them. Together, we have to continue them. Continue till the day of surgery. Among these group of drugs, there are only two drugs which we have to stop. Tricyclic antidepressant and lithium. Tricyclic antidepressant guys, these tricyclic antidepressant, it is if it remains in the blood, it interacts with our anesthetic agent and can cause arrhythmia, etc. So its total serum concentration has to go out of the body. Actually, you will seldom find nowadays a patient on tricyclic antidepressant. You won't find the patient, right? If you see a patient on tricyclic antidepressant, it has become obsolete drug. Then you have to ask the patient to stop taking it at least 3 weeks after surgery, 21 days, we need to remove their serum concentration. Got it? So stop 21 days. That is 3 weeks prior to surgery. Right? You have to stop them 21 days, 3 weeks prior to surgery. Okay? Lithium. Patient of bipolar mood disorder on oral lithium therapy. We have to stop it 24 to 48 hours prior to surgery. Stop 24 to 48 hours prior to surgery. Now guys, if both are given in the option, 24 hours and 48 hours both, go for 24 hours as an answer. This was asked in AIMS exam, that a patient on oral lithium therapy, how many hours prior to surgery we have to stop? 24 hours, 48 hours, 72 hours, 96 hours. Answer is 24 hours. I would go for 24 hours, right? So this is the recommendation regarding these drugs. Now comes anticoagulants. Anticoagulants. Aspirin, clopidogrel, ticlopidin, warfarin, low molecular weight, heparin, unfractionated heparin, fractionated heparin. Okay, very important. Aspirin, guys, if a patient is on aspirin, how many days prior to surgery we stop? This has a lot of answer, variety of answer in guidebooks, a lot of confusion in the mind of students. First confusion comes, madam, it is high dose aspirin, low dose aspirin. Well, it is never high dose aspirin. No one is on the analgesic dose of aspirin for a regular period of time. It's always low dose aspirin. It's always ecosprin, 70 to 150 milligram, low dose aspirin. So it's no question of high dose aspirin. If aspirin is written, always it's ecosprin, low dose aspirin. Okay? And if a patient is on low dose aspirin, guys, continue till the day of surgery. Actually, when we were stopping all anticoagulants, it was causing more harm rather than benefits. They are started for some reason. If we simply stop them, right, they were causing more harm rather than benefit to the patient. So what was done in 2010, the recommendation was upgraded, changed. Continue aspirin till the day of surgery, don't stop it. And rest of the anticoagulants you stop prior to surgery. Rest of the anticoagulants you stop prior to surgery. Right? You continue the aspirin and rest of the anticoagulants you stop prior to surgery. Got my point, everyone? So aspirin continued till the day of surgery. Continued till the day of surgery. So we have to continue it for all surgeries, guys. Right? We are doing it, have to do it. Okay? Clopidogrel, stop 7 days prior. Ticlopidin, stop 14 days prior. Warfarin, stop 3 to 4 days prior. Low molecular weight heparin, stop 12 to 24 hours prior. Unfractionated heparin, last dose, stop 6 hours prior. Last dose has to be given at least 6 hours prior to surgery. Okay, so this is the recommendation for anticoagulants. Aspirin has to be continued till the day of surgery. Clopidogrel stop 7 days prior to surgery. Ticlopidin 14 days prior to surgery. Warfarin 3 to 4 days prior to surgery. Low molecular weight heparin 12 to 24 hours prior to surgery. And unfractionated heparin 6 hours prior to surgery. Got it, everyone? This is regarding anticoagulants. Now comes thyroid medication. Thyroid medication. Patient on thyroxine. Patient on thyroxine. Thyroid medication. Now guys, thyroid medication, we have to ask the patient to judiciously continue till the day of surgery. If my patient has not taken her morning thyroid medication, I ask my patient to take and maybe then take the patient as my second case instead of first case. You get my point? We have to ensure that she has taken her thyroid medication. So continue till the day of surgery. Continue till the day of surgery. Okay, steroid. Patient on steroid. There may be so many patients on steroid. All tumor patients, neurosurgery patients would be on steroid. Most of your asthmatic patients would be on one or other steroids. So many other patients also on steroids. So many your let's say herbal medicine etc. have steroid. If a patient is on steroid, right, then what do we do? Well, if a patient is on clear-cut steroid, like your steroid for inpatient posted for neurosurgery etc. etc., patient is on steroid for last then 3 to 4 days. Last 3 to 4 days. What happens? If someone is on steroid, taking steroid, then his hypothalamic pituitary axis is inhibited and cortisol synthesis is inhibited. We need cortisol every day, and in stress we need 3, 4, 5 times more the normal dose. So if I stop steroid and hypothalamic pituitary axis is inhibited, this would further become detrimental. So not only I continue steroid, I go for a perioperative supplementation. Got it? So gone are the days when people think that continuation of steroid till surgery, till the day of surgery would increase infection in the patient or gut injury in the patient. No, no, no guys. We continue with a perioperative supplementation. Got it? Continue with perioperative supplementation. Continue with perioperative supplementation. Right? Well, patient is on 50 milligrams steroid per day. What do I do? 2 days prior to surgery, 100 or 200 milligram. Then on the day of surgery is 100 milligram. Post-op, 100 milligram. Then I taper it up. But we go for a perioperative supplementation. Now in AIMS they asked a 40-year-old non-diabetic female posted for frontal lobe glioma surgery. Which order has been given incorrectly by the junior resident? Options: head wash by chlorhexidine shampoo, pre-op antibiotic prophylaxis, pre-op anti-epileptic prophylaxis, stop steroid, which is wrong order. Now prior to neurosurgeries nowadays we don't get a head shave done. We get a head wash by a chlorhexidine shampoo done. Just an hour prior to surgery or 2 hours prior to surgery we get a head shave done to prevent any bacterial contamination. Number of neurosurgeons they themselves shave the head of the patient, right? You're getting my point? So 1 or 2 hours prior to surgery you get the head shave done. Okay. Then always before a major surgery we have to give a pre-op antibiotic prophylaxis. Always before a neuro intracranial surgery we give a pre-op anti-epileptic prophylaxis. Stop steroid, incorrect. We don't stop steroid. We go for a perioperative supplementation, increase steroid. But in AIMS they asked non-diabetic. Now this recommendation has 3 contraindications. 3 conditions where we cannot continue steroid. So contraindications of this recommendation, Number 1. Contraindication of this recommendation, number 1, diabetes. Then number 2, active infection. Number 3, immunodeficiency. So these conditions, I can't do this, can't continue. So what do I do in this? I stop steroid, wait for the hypothalamic pituitary axis to get normalized, maybe get a serum cortisol level done, and then take the patient for surgery. Got it? So this is what is the recommendation. Any other drug you want to ask from me? Don't ask. Continue till the day of surgery. Whatever drug had a recommendation, I had given it. Any other drug comes in your mind? Don't ask. Continue till the day of surgery. Guys, question. A 24-year-old female on regular oral contraceptive pill for birth control was posted for some surgery requiring general anesthesia, right? Which of the following recommendation is correct, right? Which of the following recommendation is correct? Stop 2 weeks prior to surgery. Stop 4 weeks prior to surgery. Stop 6 to 8 weeks prior to surgery. Continue. Guys, is it in our group? We have discussed everything which we have to discuss. Is it in our group? No. Continue till the day of surgery. Previously, there was orders regarding oral contraceptive pill because previously high estrogen pill was used, which increased the episode of post-op thromboembolism. Plus, previously, there was more long period of immobilization after surgery. Now ambulation is also fast and it's low dose estrogen or only progesterone pill, which doesn't increase the risk of thromboembolism. So recommendation has been removed. Continue till the day of surgery. Whatever, I'm giving you one example. Otherwise also, whatever we have discussed, that's it. If we haven't discussed a drug, continue over statins, continue till the day of surgery. Got it? Even if you don't continue, we have no problem. No anesthesia or surgical risk associated with it. But what is the approach? If drug has no recommendation, continue till the day of surgery. Got it? Okay guys, I have a smoker posted for surgery. Lap cholecystectomy. Moderate surgery. And I went to see him 12 hours prior to surgery. And what he was doing? Smoking at that time also. So what should I do? Ask him to stop smoking and then I wait for some time and then take the patient for surgery? Or I simply ask him to stop smoking? What say? Well, I simply ask him to stop smoking at least till the day of surgery, till the surgery. There are immediate benefits of stopping the smoking. When you stop smoking within 12 hours, the carbon monoxide and nicotine level of the blood reduces. What does carbon monoxide do? Shifts the oxyhemoglobin curve towards the left side. So oxygen delivery reduces and nicotine resets the carotid and aortic baroreceptor, tachycardia, etc. happens. So what do? I simply ask him to stop. Within 24 hours of stopping the smoking, the oxyhemoglobin curve shifts to right side. Within 48 hours, the ciliary function of the respiratory tract improves. Within 72 hours, mucus hyperproduction decreases. So there is clear-cut benefits of stopping the smoking, right? After every 12-24 hours. But we don't wait for 48 or 72 hours for all the benefits of stopping the smoking. Before major surgery, we can think of it, but moderate minor surgery, we don't think of it. So we simply ask the patient to stop smoking prior to surgery, at least till the day of surgery. But if I have a thoracic surgery, if I have a, let's say cardiac surgery, and I want a good chest preparation, good lung preparation, in this patient I can wait. There's a question asked that how many weeks prior to surgery should a person stop smoking for a complete reversal from all ill effect of smoking? Okay, 12 weeks. We need at least 3 months of stopping the smoking for complete benefit from all ill effect of smoking. So a gap of 12 weeks, 3 months required for complete reversal from all ill effects of smoking. Got my point? Understood this? Okay. Well guys, I have a patient posted for, let's say, lap cholecystectomy, and when I was doing his pre-anesthetic evaluation, he told me, doctor, I had coronary stenting done 2 weeks prior. I had put a drug-eluting stent. This is the details of my stent. And I am on multiple anticoagulants, clopidogrel, this, that, etc., etc. So, is it reasonable to ask him to stop his anticoagulant and then take him for the elective surgery? Because when we stop these anticoagulants, it can cause stent thrombosis. Guys, is it reasonable to do it? No, it's not reasonable. There is a recommended minimum gap between a coronary stenting and an elective surgery. Okay? So we have to know that. If a patient is placed with a medicated drug-eluting coronary stent, then there should be a gap of 1 year between stenting and surgery. And if a patient has been placed a bare metal stent, there should be a gap of 1 month between the stenting and surgery. So, a gap of 1 year required between drug-eluting coronary stent and elective surgery. A gap of 1 month required between bare metal stent and elective surgery. Got it? Right? So this we have to remember. Okay, so this is all about our pre-anesthetic evaluation. We discussed how do we do pre-anesthetic evaluation. We discussed ASA grading. We discussed airway evaluation with a focus on Mallampati grading. And we discussed pre-anesthetic order, in which we focused on nil per oral order and we focused on your orders regarding previous medications and some special recommendations, right? So this finishes our pre-anesthetic evaluation, a very important topic from exam point of view. If you pick up the last 5-year paper, every year there is a question on pre-anesthetic evaluation. Last AIMS they asked, last All India they asked regarding Mallampati grading, last AIMS they asked regarding the steroid, last to last AIMS they asked regarding lithium therapy. So every year there is a question. If you just follow these things also, the questions would be solved. Okay.